Hey everyone, so today I'm going to be doing a presentation about acute pancreatitis, and in this presentation I'm going to go over a clinical presentation, diagnosis, treatment, essentially the basic things you have to know about acute pancreatitis. And this lecture is primarily targeted towards medical students who are studying for their STEP examination. So the first thing I want to start off with is clinical presentation. So say you have a patient who comes in reporting abdominal pain. How do you differentiate just on the basis of clinical presentation whether this patient has acute pancreatitis or not? And the truth be told, it's incredibly difficult to distinguish acute pancreatitis with other causes of abdominal pain just on the basis of clinical presentation. But just to go over it, acute pancreatitis often presents with epigastric pain that radiates to the back. Along with that, patients will often report nausea, vomiting, they may have fevers or chills, but the classic thing to remember is epigastric pain radiating to the back. Because that's often the classic presentation of acute pancreatitis, often when it's tested on NBME examinations or STEP examinations, often they don't use that classic presentation. One thing I also want to briefly mention is it is important to be aware of, based on where the location of the abdominal pain is, what the differential might be. So if a patient comes in with right upper quadrant pain, it's important to think about acute cholangitis, acute cholecystitis, hepatitis. Epigastric pain, as we talked about, acute pancreatitis. It's also important to remember if someone has pain radiating in the back, it's also important to consider aortic dissection as well. Apart from that, if a patient has right lower quadrant pain, you're thinking about acute appendicitis, left lower quadrant pain, diverticulitis. These aren't the only causes of abdominal pain, but those are, I think, some of the common ones that you should have at the top of your head whenever you're dealing with a question about abdominal pain. So once again, I think that's pretty much it with regards to clinical presentation. Next, I want to move and talk about the diagnosis of acute pancreatitis. Now, diagnosis is very easy to remember because the guidelines are to diagnose acute pancreatitis, you need 2 out of the 3 below on this list. One is the typical abdominal pain, which is, once again, epigastric pain that radiates to the back. That can be one of them. The second patient needs to have either serum amylase or lipase more than 3 times the upper limit of normal. The reason in here I just listed lipase is that in general, even though it can be amylase, lipase is preferred because it's a much more sensitive marker for acute pancreatitis. Amylase, on the other hand, can be falsely high in a lot of conditions that involve cell pathologies that are related to the mouth, whereas lipase is typically only high in acute pancreatitis. So that's another possibility. The last thing, in order to make the diagnosis of acute pancreatitis, is CT findings that are consistent with acute pancreatitis. And that means fat stranding around the pancreas, a pancreas that's large and edematous. And so once again, to make the diagnosis of acute pancreatitis, you just need 2 out of the 3 below on this list. And once again, they are typical abdominal pain, amylase and lipase, which are elevated above 3 times the upper limit of normal, and then characteristic CT findings of acute pancreatitis. And it's also important to remember that if you have a patient with elevated lipase and typical abdominal pain, you actually don't have to get imaging, because that by itself, just that classic abdominal pain and the lipase findings are enough to make the diagnosis, so you don't have to actually do imaging to make the diagnosis of acute pancreatitis. That's very high yield to remember. The next thing I want to talk about is what are the causes of acute pancreatitis? And on this list, I included 5. I'm just going to focus on the top 3 because these are the ones that you actually see most commonly, particularly in an inpatient setting. So the first most common cause is gallstones. So what happens is that pancreas, one of the things that it does is it's producing these enzymes which break down food. And in order to get these enzymes into the small intestine to break down food, it has to go through a duct. Now, that duct is that it uses to secrete these enzymes is the same duct that's used by the gallbladder to release bilirubin. One of the things that can happen is sometimes if there are stones in the gallbladder, those stones can essentially come down and block the exit pathway for the pancreas. And when it blocks that exit pathway, that in turn can cause acute pancreatitis. So gallstones is a very frequently cause of acute pancreatitis. Along with that, patients who have an extensive history of alcohol abuse, they can also have acute pancreatitis. It's a very common cause. And the next one that I want to focus on is patients who have very high levels of triglycerides, typically above 1,000 or more. That can also be associated with acute pancreatitis. The reason this slide is very important to remember is when you have a patient with acute pancreatitis, it's important to ask about all these things. So you'll ask them, can you please tell me about your history of alcohol use? Can you tell me about whether you have any prior diagnosis of lipid abnormalities? And then when you're doing testing, you'll test for these things. So this slide is incredibly high yield, particularly in a clinical setting when you have a patient with acute pancreatitis. The last thing I wanted to focus on is treatment. Acute pancreatitis, unlike a lot of other medical pathologies where often you have to consult surgery for treatment or you have to start a patient on medications, acute pancreatitis can actually be managed very simply and conservatively. So what you do is when you have a patient with acute pancreatitis who comes to the hospital, you'll start them, make them NPO. So you essentially just don't give them a diet, don't give them liquids, and just essentially do bowel rest. And the thing is, you want to try to start a diet as soon as possible, but you want to tell the patient that whenever they're ready, then you start a diet. So once again, the first step you do is make the patient NPO, and once they're ready to start a diet, start them initially on a clear liquid diet. So that's the first step, which is making the patient NPO and then starting the diet as tolerated. The second step is you want to really aggressively give the patient IV fluids. And the last step is you want to make sure you're very aggressively treating the patient's pain. So those are, once again, the three cardinal ways in which you're managing acute pancreatitis, which once again, it's very conservatively. You're making the patient NPO, you're giving them IV fluids, and you're giving the patient pain medication. And just through that, that's how you manage acute pancreatitis. You don't have to contact general surgery, you don't have to start them on any particular medication, you're just managing them conservatively. The one thing that I'll mention now that we're talking about management is if for whatever reason a patient's acute pancreatitis isn't getting better after a day or two and it seems like they're having increasing fevers, they're becoming more hypertensive, that's when you definitely want to do some repeat imaging of their CT abdomen pelvis to look at the pancreas. Because if their clinical presentation is worsening, what you're worried in that situation about is complication of acute pancreatitis like pancreatic necrosis. But once again, as we discussed earlier, you don't have to get imaging of the pancreas to make a diagnosis. But if the patient, once again, does start clinically deteriorating, then you do want to get imaging to rule out if there's any pancreatic complications. And I think that's going to be it for today's lecture.